A very warm greeting to each and every one of you. Thank you for joining us today. Welcome to the 2024 International Conference for Healthy Aging and Nutrition, hosted by the National Center for Geriatrics and Welfare Research, National Health Research Institute. I'm your MC of today. Please feel free to come to me with any request. I will be glad at your service always. Yesterday, we have engaged in some nutritious dialogues, thankfully calorie-free. In this event, scientists and scholars from Canada, France, Thailand, the US, Hong Kong, Singapore, and Taiwan share their insights to help us keep fit, active, and aware of the changes that come along with aging. After all, aging is inevitable, but slowing it down seems to be humans' longest running DIY project. Today, we are diving into identifying factors from basic science to clinical application that support our understanding of how nutrition can shape our health. It's great to know that aging can be complex, but not entirely out of our hands. So let's look forward to an inspiring and informative day ahead, full of ideas that make aging more like a graceful marathon instead of a sprint. Now we are honored to invite Professor Lin Zhengjie, the Vice President of China Medical University, to the podium to introduce our keynote speaker. Professor Lin specializes in family medicine, geriatrics, and preventive medicine, focusing on holistic family care and comprehensive disease management. We are honored to have him chair this session.
Dear distinguished guests, Vice President Dr. Professor Shi, good morning. I extend a warm welcome to all of you to the keynote speech of the International Conference for Healthy Aging and Nutrition. I'm Zhengjie Lin. I'm honored to introduce our distinguished speaker, Dr. Keller, a renowned expert in geriatric nutrition. Dr. Keller is a professor at the Schlegel-UW Research Institute for Aging and the Department of Kinesiology and Health Science at the University of Waterloo, Canada. Her research focuses on nutrition risk and malnutrition identification and the treatment across healthcare sectors. She is particularly interested in improving nutrition care in hospital, self-management, and using screening in the community to improve nutrition status. Dr. Keller is an internationally recognized expert in her field and has received numerous awards for her work, including the Earl Willard McHenry Award for Distinguished Service in Nutrition and the Mary Taylor Award for Excellence in Long-Term Care. She is also Fellow of the Canadian Academy of Health Science and the Dietitian of Canada. Today, Dr. Keller will be sharing her expertise on the topics of screening for malnutrition, risk to improve the healthcare of older adults from community to hospital setting, best practices and lessons learned. Indeed, this is a critical issue in the field of healthy aging. And I'm confident that Dr. Keller's insight will be of great value to us all. Let's welcome Dr. Keller.
So it's a real pleasure to be here, and I must say, when I received the invitation from Director Shi, I jumped at it. I thought, Taiwan, what a wonderful place to visit, and the hospitality has been amazing. So I want to thank the committee that put this session together, as well as Vice President Shi, Professor Lin for his kind introduction, our MC Flora for her wonderful work, as well as Tina, who is becoming a very good friend in terms of research, as well as other opportunities that we have in Canada and going forward. As I said, it's a real pleasure to be here. And I must say, yesterday when I was sitting in the sessions, I thought, when was the last time I was at a conference where I could get something out of every session? I often, as a geriatric nutrition expert, will go to nutrition conferences, and geriatrics is a very small component. Or go to geriatric conferences, and nutrition is a very small component. So here we have geriatrics and nutrition together, and it's been a really wonderful session. And I must say, I'm very impressed at the level of science that is being done here in Taiwan, as well as elsewhere in Asia. It's been really a pleasure to get to know what's going on and where we're going. So I'm going to be talking about screening in hospital and community settings. That's one area of work that I do. But I also do work in long-term care. So if you have questions about long-term care and nursing home in Canada, certainly can address some of those questions you may have as well. I do work around trying to promote hydration in long-term care and improve food intake in that setting, as well as improving the mealtime experience of people living in long-term care. One of my other key areas I work in is dementia, specifically in the community with older adults, trying to provide a hope, basically, around well-being for people living with dementia and their caregivers. And so we have nutrition education programs, cooking programs, and exercise and nutrition programs that we do in my university around that area. So again, if you have any questions in that area, please let me know. So first off, there we go. Got it now. My disclosures, just so you're aware. So today, as I said, I want to cover off what is malnutrition and why it's relevant to the older adult. And I'll be giving you statistics from Canada, but also some data from other places in terms of treatment and benefits of treatment. How do we recognize malnutrition risks, specifically in older adults, and what can be the tools that we should be using in these various settings that we're looking at, hospital and community specifically? Then I want to talk specifically about best practices that we have developed in Canada that are transferable to other places. And I know in Taiwan you already do have some best practices in place, but maybe these might give you some ideas to enhance those further. And then finally, lessons learned in implementing screening, specifically in the hospital setting, where we've done a study over the last decade, actually, around identifying nutrition problems in the hospital and how they can be improved upon. So first off, what is malnutrition and why is it relevant for older adults? And so this is a definition that I like to use. It's actually consistent with the Cederholm definition and others that are out there as well. The idea that it's an adequate intake or assimilation of energy, protein, and or micronutrients, but it has to be sustained so you actually see functional change in the body. That could be cognition, it could be immunity, weakness, muscle loss, and affects capacity for recovery. A key difference between sarcopenia, for example, or cachexia, or frailty and malnutrition is it responds to refeeding. That's the key difference. When we feed someone, when they're not been fed as well, or they're having assimilation challenges, if we refeed properly, you do see improvement in malnutrition. However, of course, inflammation impacts the capacity to respond to feeding, as we well know. So malnutrition risk is a little bit more of a challenging term to define. Lots of people have different definitions of this. I'm using mine here. But basically, I consider this as risk factors that are present or known to be associated with impaired food intake or affect nutrient utilization. It's low or poor food intake for a sustained period of time. It occurs before you start to see the physical changes or overt signs of malnutrition, such as significant weight loss. And it's definitely easier to improve nutritional risk and why we should be finding nutrition risk when it exists, especially in the community, so we can reverse it and prevent malnutrition. As well, nutrition risk is commonly measured by looking at accumulation of risk factors, food intake, and weight change. So many of the screening tools we use have these components. This is a way that I conceptually think about nutrition risk in the community living older adult in relation to malnutrition. So it's a somewhat simplistic view. We'll show a slide in just a moment showing the complexity of malnutrition in older adults. But there's determinants and risk factors. Oh, I don't know why it advanced on me there. Determinants and risk factors for food intake, such as a low socioeconomic status, transportation challenges, maybe living alone. All of those can lead to changes in food intake. And if those changes in food intake are significant enough, we start to see weight changes or recommendations around dietary intake not being met. Over time, if that continues, that can lead to than the significant overt signs of malnutrition, such as muscle loss, weakness, and health events like hospitalizations, ER admissions, falls, etc. We do know, however, that malnutrition is more complex than that, right? There's the inflammatory process on top of this, especially disease-related malnutrition. And it's a very complex process. So the layering on of sarcopenia, as well as increased catabolism, endocrine changes, for example, and then some of the physiological changes like fatigue and loss of appetite that keep going in a cycle to leading towards malnutrition in older adults. I show this to demonstrate we need to intervene as soon as we can in this cycle. So this is, again, why nutrition risk screening is important, to find these people early on in the process so we can intervene and prevent that malnutrition. So a group in Europe developed this path, or framework, I should say, for what is malnutrition in older adults specifically. And so you can see at the center, the MN stands for malnutrition. The dark green triangle pieces are the mechanisms by which malnutrition occurs in older adults. So low food intake being one of them, and one that I tend to focus in on in the community setting especially. Reduced nutrient bioavailability, which is not as common, and high requirements, which can be common with inflammation in older adults, or when they've had a wound or they've had surgery, that sort of thing. You can see then around those dark green triangles is a lighter green triangle. And this is what they consider the direct predictors or direct risk factors, if you will, for those three mechanisms. So for example, inflammation would lead to high requirements, which over time, if not being met through the diet, would then lead to malnutrition. Or with respect to chewing problems, that would affect food intake. There's quite a discussion yesterday about oral health, huge part of nutrition, right? And so chewing problems and swallowing problems could lead to poor food intake or low intake. Then things like reduced nutrient bioavailability would be due to diarrhea. Not as common as we would see with the high requirements or intake, but certainly does happen. Malabsorption syndromes, etc. The yellow triangle are those indirect determinants of those factors. So for example, malabsorption might be due to cancer in the gut, or it might be due to a gastrointestinal disease. The increased metabolic rate that we see in the light green triangle might be due to COPD or an inflammatory disease. Okay, so they're not the direct determinant. We have to have the inflammation, but the disease state that leads to that is the indirect determinant. And when it comes to food intake, it'd be things like, for example, poverty, which might lead to poor dentition, which then leads to poor food intake. So now you can see the complexity of the risk factors that we have when thinking about malnutrition. The red letters on the outside are things that we know to be associated with malnutrition, but it's questioned, are they really direct effects or just things that are associated? Like, for example, hospitalization, right? Or low education. So it's certainly associated with nutritional status, but the impact can be variable. It might not be direct or indirect through these pathways. This is a hypothetical model, and so it's being tested now when people have very large data sets, and I don't know if you're familiar with this model or not. We have such great data in Taiwan, it might be worth actually determining if this framework actually is consistent with what data has shown us. I've done it recently in the NHANES data using low body weight and weight loss as the indicators of malnutrition. And not all these factors actually fit the way that we hypothesize. So it's worth thinking about doing more research in this area to really determine what are the key things we need to focus in on. Because if we focus in on those factors, that could help us to, again, prevent malnutrition. So I'm going to switch now to talking about some of our Canadian data. This study was in 18 hospitals in Canada, over 1,000 patients. And in Canada, we have universal health care, but each province is different. So getting provinces to come on board for a study like this was quite challenging, if you can imagine. And we had, over 1,000 patients. They were not all older adults, but the average age was 67 years. So a good portion were obviously older adults. What I wanted to highlight for you here was using subjective global assessment, which is a standardized way of determining malnutrition. We found 45% to be at some level of malnutrition coming into the hospital. Now, these are patients who were in hospital for at least 2 days. So those quick turnaround admissions are not this population. So 2 or more days in hospital. And when we looked at the extended length of hospital stay for these patients, it was 2 to 3 days, which was basically at the time of the study, which was 2017 or so, $2 billion a year, which is a huge amount just in hospital day costs. That doesn't take into account extra surgeries or other activities in the hospital like medications or dealing with wounds. It's just the actual bed stay that cost. It also doesn't take into account post-hospitalization, what might happen to those patients, readmission, perhaps need for home care and other activities. So this is a huge cost with malnutrition, obviously in Canada. And I think we could say that for many countries in the world. We see malnutrition being hugely costly to the system, and especially the acute care system, which drives a lot of the healthcare costs, at least in North America. But it starts in the community. People come from the community into hospital. And so we were one of the few studies that actually looked at admission, what was their nutritional status, but also what were some of the things going on at home before they came into hospital. And we identified that older adults were more likely to be malnourished on admission to hospital as compared to younger adults or under the age of 65. If they needed help with food-related activities of daily living, like grocery shopping, they were also more likely to be malnourished. And they had greater comorbidity. So again, not surprising that that's associated with malnutrition. But hospital provides us an opportunity to identify malnutrition if it's not being identified in the community. And that's why we focused in on hospital malnutrition initially with this work. But it also says we need to be doing something in the community to try to prevent this malnutrition. In this same study, we actually did post-hospital data collection as well. So this is a very comprehensive data set. We did pre-admission, we asked them about what was going on pre-admission. During admission, we assessed their malnutrition status using standardized methods and lots of data collection around what happened to them in hospital. We followed them right through their hospital admission, and then 30 days post-hospitalization, we phoned them up and also identified what happened to them. So a very comprehensive view of the visit to hospital and what was going on around that time. We found that patients who stayed more than 7 days in hospital, 20% deteriorated. So it says something about our hospital system, doesn't it? Whether it be the food or what was happening to individuals in terms of interventions that were going on that might impact their food intake. We also identified in this study when we did the follow-up phone calls that about 20 to 26% reported weight loss 1 month post-discharge. And this was due to having a new diet prescription and a poor appetite. So we weren't doing a very good job of identifying those that were malnourished leaving hospital and giving them a good education about how to address their dietary needs when they went back in the community. So this study was really about identifying those gaps in care so we could figure out what we needed to fix in our Canadian hospital system. We also found that those who were malnourished and left were 2 times more likely to be readmitted back into the hospital again. Not surprising. Again, data that's very similar to other places that have done this work. In the community, though, and this is not Canadian data, this is European data where they looked at malnutrition using a very simple definition of malnutrition because it's large studies and they can't do subjective global assessment, for example. They looked at using BMI less than 20 kilograms per meter square or weight loss or the combination of the two together. On the far right-hand side is nursing homes. You can see that the prevalence of malnutrition is higher in the nursing home setting. Again, not surprising considering the capacity of individuals, eating challenges, dysphagia, dementia. In the middle is acute care hospital is the next group of bar graphs there, showing that it's high depending on some of the studies. Then we have home care, which is people getting care in the community because they have quite limited capacity, maybe for mobility or medication management, that sort of thing. And then the far left is people that are healthy or thought to be healthy in the community. And you can see the malnutrition prevalence is much lower in that group. Right, so that group there. But what is more prevalent is nutrition risk. So we're going to switch now from talking about malnutrition, which has that functional changes in the body, significant weight loss, affects health outcomes, to nutrition risk. And this is probably a more relevant concept for the community living older adult. So again, thinking about that diagram I showed you, upstream factors that impact food intake, which long-term can have an effect then potentially on nutritional status. So based on the Canadian longitudinal study of aging, which is a very large study in 40,000 persons living in the community, older adults, we have two segments, one that's 25,000 participants that has an in-depth data collection, and 30,000 which has a little bit less in-depth data collection. This is based on the more comprehensive group. So those over the age of 45 years, so it starts at 45 and goes on. It's a panel study, so every 3 years they collect data from the same people. So over time, this is going to be a very rich data source. We now have 3 waves of data collection in this sample. So looking at the baseline data in this population sample using the Screen 8 questionnaire, which I'll talk about a little bit more detail, about a third were high nutrition risk. Okay? So it's not malnutrition risk, it's nutrition risk, that upstream view of it. So who are these people that are at nutrition risk in the community? Looking again at this data set. They tend to be women over the age of 75 years, low income, living alone, low social participation and support, depressed, disabled, polypharmacy, poor oral health again, comorbidity, and lower life satisfaction. So not surprising that we see risk then in this group. That profile seems consistent with what we would think about malnutrition as well, right? And when we look at the individual markers of nutrition risk based on screen, this is actually a study in over 12,000 people done by a colleague of mine in Netherlands. They used the whole 14 items of the screen tool, and you can see the prevalence of the various risk factors using this tool across 3 countries. We have Netherlands, New Zealand, and Canada this data was from. So 49% had a weight change. 14% of that weight change was unintentional. 38% were skipping meals. 50% were limiting or avoiding foods because of a health condition. 21% had fair or poor appetite. 19% using oral nutrition supplements. 42% sometimes or rarely eating with others. 53% consuming 3 or fewer vegetables or fruits a day. 42% consuming 1 or less meat or alternatives a day. 60% 1 or less milk or dairy products a day, 37% less than 5 cups of fluid, 18% swallowing difficulties. This is self-reported on one single question. Did they have swallowing or chewing difficulties? And then finally, 50% difficulties with cooking and 23% difficulties with shopping. So you can see these risks are quite prevalent in our community setting, at least in these 3 countries, and worthy of thinking about. These might be opportunities for intervention. For example, eating alone. If that's a risk factor, that might then be intervened with a community center program. In Canada, we have congregate dining programs. People go to a recreation center and eat a meal together, or a meals program or something like that. So these are opportunities for intervention, as you can see. The consequences of malnutrition or risk are well known, but I just wanted to remind you of them here. So risk is significantly independently associated with health outcomes like falls, hospitalization, ER admissions, self-reported health, and low satisfaction in life. With a 2 to 3 year follow-up again in this Canadian data using the screen tool, we saw increased hospitalization and mortality. As well, increased use of healthcare resources like medical consultations, hospital admissions, and a longer length of stay in hospital, as I showed you with the hospital data, as well as more comorbidity and disability. So lots of reasons to consider why we need to be intervening again early when it comes to nutrition risk or malnutrition risk. So now let's switch to looking at the signs of malnutrition risk and the tools that can be used in this setting. So we tend to see people looking in terms of small, in terms of weight loss perhaps, weakness, low tolerance, slow recovery from illnesses or recovery from a wound, a surgery, and anarchy of aging. But this interesting paper just a few years ago published looked at the overlap between malnutrition, sarcopenia, and frailty. And there's a high overlap. So the value that's in black is the overlap between malnutrition and frailty. About half of the people identified to be frail are also malnourished. And similarly for sarcopenia, about 40% that are sarcopenic are also malnourished. So when we're thinking about measuring sarcopenia or measuring frailty in the community, we should also be measuring nutrition risk, because that again is an opportunity for intervention with these individuals. I'm sure you've heard of the Global Leadership Initiative for Malnutrition. How many people have heard of that? Hands up? A few? Yeah? So I'm actually part of the working group for the GLIM from the very beginning. And this is the original paper that talks about the framework for diagnosing malnutrition in any healthcare setting. And I wanted to bring this up because what it has done is helped us to come to a consensus globally about how to think about malnutrition, so we can compare prevalence now across nations, and we can think about ways to intervene in a way that, and measure outcomes as well with a diagnostic framework such as this. GLIM starts with nutrition risk screening, and I'll be talking about screening from now on around hospital and community screening. That's a very important step to lead people into the diagnostic step. It's suggested that they collect more data through standardized exams such as subjective global assessment to determine if people have phenotypic or etiologic criteria. And if a person has at least one phenotypic criteria and one etiologic criteria for malnutrition, they're diagnosed as being malnourished. Those criteria are non-volitional weight loss for the phenotypic, low body mass index, reduced muscle mass. And there's they give different indicators depending on ethnicity as well for that. Etiologic criteria are reduced food intake or assimilation and disease burden and inflammation condition. I'm working with a working group right now to better define that reduced food intake and assimilation criteria because that's poorly defined in the guidance at this point in time. And so we have an international group working on developing better guidance around that. So as I said, if someone identifies one of those phenotypic criteria and one etiologic criteria, we then determine severity by looking specifically at the phenotypic criteria as well. But to make the point that risk screening is the starting process, and we'll be going on from here now to talk about tools. So there's a lot of screening tools out there. There's more in hospital than there are for community. Relatively few that are valid and reliable for older adults, and I'll focus in on those specifically. But the key is that you want to use a valid and reliable tool designed for the correct sector that you're working in. So you don't want to use a tool that's meant for hospital in a community setting. The reason being the risk factors there are very different. I'll show you that with the Canadian Nutrition Screening Tool. You want to also make it very easy to do. We've talked about a lot over the last day intervening with people who have low appetite or intervening with people who have malnutrition. But how do you find those people in the first place? This is screening. And you have to put it into place in many ways, primary care, recreation centers, hospitals, a variety of places. It should be happening in all sectors of care because it is so prevalent. We have to make it very easy, though, to be able to do screening in these settings. And I'll talk more at the end about implementation. A very large study that we did in Canada called More to Eat. We implemented screening in a hospital, the learnings from that. It's best to actually have tools that don't require measurement because then it's going to be put into place much more readily. And again, we'll talk about the Canadian Nutrition Screening Tool as an example of that. And after you've got your tool selected, you have to do something with it. You can't just screen people and not do anything, right? You have to have a plan of action, and that's very important. That tends to be the stumbling block, especially in primary care. So these are some examples of some tools. Screen we'll talk about in more detail, the M&A, which we'll talk about in detail as well, and then the MUST, which is out of Bapen Society in the UK. So these are some of the key valid and reliable screening tools. So for hospital, NRS 2002, the M&A SF, MUST, MST, and CNST. The ones in blue I'm going to be talking about in a little bit more detail. In the community, we have the M&A SF, which is a short form version of M&A, SNAC 65, and Screen, which I'm going to be focusing in on. That's a tool I actually created 25 years ago now. It's a long time ago, I guess. So the key thing to remember, again, back to this diagram, is that these tools can pick up different things. So Screen is actually the only tool that is very upstream. So if you're trying to intervene early in the community, that might be the tool that's for you, okay? Many of these tools, as I said, are designed for hospitals, so they're very downstream. CNST is a Canadian Nutrition Screening Tool meant for hospital. If we were to use it in the community, it would way over-identify nutrition problems. It's not appropriate in that setting. MUST and MST are predominantly used in the hospital setting as well, but they are used in community too. NRS 2002 is predominantly only hospital use. MNASF is used in hospital and community. However, it doesn't get at all the determinants or risk factors that screen does. And then SNAC-65 is a very short tool developed in the Netherlands. What I wanted to show you here is that Borkent, a colleague again in the Netherlands, he was a PhD student doing this work, they actually used a screen tool, that's on the far end side, as well as a SNAC in the same population. And I wanted to show you that it picks up different things. When they use a SNAC, which looks at arm circumference and weight change, only 14% were malnourished in the community. But when they use screen, 70%, which is quite high, right? There were risk factors that were leading to poor food intake. So sort of what we were seeing with Philippe's presentation, high proportion of people identified at risk, and what do you do with them? So the M&A, the full version, is considered a standardized method of assessing malnutrition, and the short version is considered screening. So the full items are here that you can see. They include BMI and or calf circumference. Let's jump ahead, hang on, back up. Calf circumference and BMI. This can be a limitation if you're trying to do it in some settings. People might not have the skill, so that can be a challenge to do it. The short form is only 6 items, and why it's used then for screening. Screen is quite different, as you can see. So the items that we have are loss and gain. This is the only tool that actually measures weight gain, not weight loss only. Because certainly obesity is a challenge too in the community, right? And it can be negative, not just a positive to weight gain. Intentionality of that weight change. So again, that's a unique feature of screen. Perception of the weight. Skipping meals, diet restrictions and difficulty, appetite, eating alone, use of meal replacements, intake of fruits and vegetables, milk products, meat and alternatives, fluid, swallowing challenges, chewing challenges, grocery difficulty, and shopping difficulty. Cooking difficulty, I should say. The asterisk is for those items that are on screen 8, which is a shorter version. And we also have items that are on what we call screen 3 extended. So I'll just spend a little bit of time explaining that. When screen 14 was created, people said, oh, it's a wonderful tool, but it's too long. 14 items is way too long. And so we developed screen 8, and it's used in a lot of epidemiological surveys in Canada as well as other places. But even that, in a clinical setting, people said, oh, 8 items is too long. Let's try to have something shorter. And so we did some work in the Kinesiology study of aging where they had screen 8. We identified that 3 questions should be asked first. If someone passes those, you do not need to ask the remaining 5 questions. But if they don't, then you should ask the remaining 5 questions to clarify if they're nutrition risk or not. So it's a way of reorganizing the questions so that you can limit those people that have to go on to the full completion of screen 8. And at the end of the presentation, and I'm pretty sure the presentation can be made available to anybody who wants it, there's references for all of the information here. So if you're interested in looking at screen, it is on this website here. And in addition to the screen tool, there's training as well on the website, fact sheets to use with clients. And I'll show you what some of those look like in a moment. And it's a popular website because it does provide these handouts that are pinned to each component of screen. And this helps for self-management. And so one of our provinces in Ontario is planning to actually create a self-management website using this tool and using some of these fact sheets so that people can go in, identify their risk, and then get some advice, guidance here around things like protein intake or difficulties chewing and swallowing. This is a CNST, and you can see why it might not be appropriate for a community setting. But interestingly, about it as well, there's no measurements. So this is a bit different from some of the other hospital-based questionnaires. And we did that because we knew from the literature that one of the greatest barriers to doing screening in the hospital is getting a weight on a patient. I'm not sure if that's the same issue here in Taiwan or not. But in Canada, at the time that we did that very large study in 1,000 hospital patients in 18 hospitals, body weight was not being measured in people. It was a relatively rare event. So lots of gaps again in care. So we thought we have to have a screening tool that's very easy to do by nursing staff on admission. And they often in the nursing admission will have one question already around appetite. Can we replace that with 2 very brief questions? You'll notice here we don't actually have appetite on here. Again, we looked at the literature and thought, well, people can have poor appetite but still be eating enough. So that's a challenge with measuring appetite. People can override a poor appetite and still eat well. Really what we're interested in is not eating enough. And so we decided to make our question more specific than that. So have you been eating less than usual for more than a week? So when we use CNST now beyond that original study being used in Canada, it's more like about 30% of people identified at risk, and 70% of those, when we do SGA, are malnourished. So it has pretty good sensitivity and specificity for identifying those individuals that truly have malnutrition. So let's now move on to best practices for screening and treatment. And so after we did that initial study showing the gaps in care and people staying longer in a hospital, and again, there's lots and lots of data that we published that I've not told you about today, but we identified lots of problems in our system, and we thought we have to develop a best practice pathway to guide hospitals towards better care. And so we created the integrated nutrition pathway for acute care, and we used a consensus-based method. We first looked at the literature to find out what other pathways were already published, and we took those and thought about the gaps we saw in our hospital study that we did, and we brought a consensus group together and talked about what are the gaps that need to be fixed. And so, for example, many of the pathways don't talk about post-discharge care. We made sure that had to be on here. Additionally, they don't necessarily talk about how in the other pathways when to move up or down a level around nutrition risk. And so we actually use food intake as an indication when someone's to move up and down in terms of levels. We'll talk about that in just a moment. So it is a unique pathway. It's been picked up actually by Australia and Ireland as well. So at the top, we start with screening. Again, we recommend the Canadian Nutrition Screening Tool because it's very easy to do. 2 questions. If a person identifies to be at risk with the CNST tool, they then would go through subjective global assessment. Back when we were doing that initial study in 2010, no dietitians were doing SGA, very, very few. It was a very rare thing that they would do. And so this was a huge change in practice, as you can imagine. So getting dietitians to do subjective global assessment, those that were identified to be severe malnutrition, a comprehensive nutrition assessment for those individuals. So going beyond that standardized SGA to get at what we need to actually improve on in terms of nutrition care. So digging into maybe some biochemistry as well as more about their dietary intake, preferences, etc. And maybe the need for enteral or parental nutrition as well. A subgroup that might be SGA-B, which is moderately malnourished, you can either, using your clinical judgment, decide to use that comprehensive nutrition assessment again or not, depending on the setting. So, for example, some rehabilitation hospitals said, well, most of our patients are SGA-B. We don't see Cs very much. So we want to do that comprehensive assessment with them as well. But in some very high-end tertiary care hospitals, they have a lot of patients coming in, right, turning over pretty quickly. The Bs are not a group they can see regularly, but the Cs they must see. So this, again, back to clinical judgment about whom they should see based on the context of their hospital. So for Bs, what we suggested is putting in an advanced care package that could be automatically applied to patients when they came in and were malnourished SGA-B. This might be your typical older adult who might just not be eating well. Okay, let's give them a high-energy protein diet, maybe oral nutrition supplements between meals, that sort of thing. It's pretty standard. You don't have to have it individualized, and it will do some good for that person, right? That's the advanced nutrition care package. So you don't have to do the individual assessment to get there. But as you can see, if after 2 or 3 days food intake does not improve in that person, they should be moved up to the individualized assessment. Why are they not eating well in hospital, right? And so this is where we use food intake to try to differentiate increased need while they're in hospital. The group that is not at risk at admission through CNST should get a standard care package. And again, I haven't shown you this data, but we had major gaps in just basic care. I can't remember exactly the stats, but I think it was something like 40% of people could not reach their tray, right? That should not be happening. And so their food was not consumed then because they couldn't get to their tray. Or they're eating in bed. Or when they went away for a test, their tray was removed. Those sorts of things. And so we wanted to put into place a standard care package about things that should be in place to make sure everybody can eat their meal in hospital. Their preferences are attended to. If they require dentures, those are put in, glasses on, sitting up in bed, that sort of thing. So the standard care package, we wanted to define what that was for people. So this is the integrated nutrition pathway for acute care. And when we put this out, there was actually quite a bit of pushback, especially from dietitians. They thought there's no way, if we have a high proportion at risk, can we do this SJ? It's going to be way too timely, use, and we're not going to see our patients that we should be seeing. So as I said, we had a lot of pushback, and so we had to lead to doing another study, which I'll talk about in just a moment after I talk about best practices in treatment. So this pathway could be put in place to do what we know works, right? And so we know that treatment will benefit patients. We didn't need to show that in our study here and in the Morteet studies. We had to show that we could implement it and sustain it, because that's the challenge, right? We know that if people get ONS, they will get better, right? Lots of studies to support that. So for example, on the left-hand side, the SBAN Guideline for Hospital Nutrition 2021 says these sorts of things should be happening in hospital. And the IMPACT is very much aligned with that. IMPACT was developed 5 years before that. On the right-hand side, we have some information about interventions that are known to work and what they do in terms of outcomes. So for example, Schutz et al. In 2021 had a very nice review paper that talked about malnutrition in the hospital and barriers around that, but also what interventions could work. So screening to identify those who are malnourished, that's the key thing, a key activity that needs to happen in hospital. Assess to individualize that treatment. Specialized protein-enriched oral nutrition supplements. We know when we put those in place, the DIT study showed that specifically, that we can improve, reduce mortality, improve quality of life. Enhanced food also has benefits to patients. The nutritional support in terms of enteroparental nutrition or oral nutrition supplements can decrease malnutrition and non-elective readmissions. And finally, dietitian counseling. So we know that all these treatments can work. The challenge is getting people to them, and that's what the IMPACT tries to do. So after the success of developing IMPACT, and again, in a few moments, I'll talk about the implementation of it in hospitals in Canada and where we've gone from there. But I still wanted to show you at this point where we went next, because we knew, again, that community malnutrition was happening, or nutrition risk was happening, especially in older adults. And we thought we needed to develop a pathway for care in the community. And at the point when we created this, we couldn't find any other ones published in the literature around community pathways around nutrition care. And you'll see that it has some similarities, but also some differences. So, for example, we should have nutrition screening and malnutrition. Oh, this is transitions, not the older adult one. So if a person comes out of hospital and into the community and they've been malnourished, that should be communicated to the medical home, primary care, nurse practitioner clinic, etc. That should be followed up in the medical home in some shape or form. The individual should be reassessed, potentially in the medical home, investigate the etiology, again, if it's continuing malnutrition is happening, provide resources to the individual, monitor the weight and appetite, monitor access to community services, and rescreen the individual annually. We talk about the need, again, for primary care and community dietitian. In Canada, this is not common. I heard from here in Taiwan that you have more community dietitians than we do. It's a pretty rare service, unfortunately, in Canada. It's mostly only in Ontario and Alberta, those two provinces. So we want dietitians to be involved in the care of these patients that have transitioned out of hospital in terms of determining their individualized needs and treatment. But you can see what we've included in this box, which is a bit unique, is the idea of community services can be very helpful as well for keeping patients in the home and not being readmitted to hospital. So meal-based programs, for example, and programs that home support agencies, etc. Again, literature tells us that when we put into place counseling or nutrition supplements, dietitian-led interventions, and food fortification and enteral nutrition in the community setting, we see benefits. Improved energy intake, protein intake, improved body weight, quality of life, decreased readmission to hospital, increased gait speed, and decreased mortality. So again, it's a relevant thing to be doing. We have to figure out how to get people to the treatment, and that's where screening comes into place. So I'm going to show you the pathway for older adults, which was also created. So these two pathways, these last two that I'm showing you, went through the very same process that we did with the one for hospital. We went through the literature, identified some of the better practices that were happening based on literature search. We then developed a consensus group to think through what this should look like. And we then sent it out to providers in the community, said, is this feasible and acceptable, the way to do these pathways? And this is what we ended up with. So for older adults specifically, because we know they're at nutrition risk, again, screening at admission, we recommend the M&A or the MUST or the SCREEN2. And for the people that are not at risk, this is where we can still intervene. So think about, again, Philippe's program. there's things we can be doing, right? So even though they're not at risk, they can still be encouraged to continue their healthy eating habits. So maybe for those group, really just resources and self-management is needed. And so building that into the care service. If they're at moderate risk, which could be quite a number of people, you want the primary care provider to investigate the etiology and diagnostics, initiate a basic care plan, which I'll show you in just a moment, monitor weight and appetite. They probably don't need to see the dietitian, because again, think about Canadian context, we don't have very many dietitians in the community. And if we were sending all that are moderate and high risk to the community, sending to a dietitian, we would overflow that readily. So in our pathway, we reserve that for the high risk individuals. So referring to a dietitian, if that dietitian is available, again, investigating etiology and diagnostics and risk factors. So for example, if they have nutrition risk and use a screen and they saw swallowing problems, a speech language pathologist would be the appropriate referral source. Initiate, again, the basic care plan while you're waiting for that dietitian referral to happen, and monitor the weight and appetite of the individual. So as I said, community dietetics, there aren't a lot of dietitians. And I live in Ontario, where we have something called family health teams. It's about 40% of the population is covered by a family health team, and they will all have a dietitian. But those dietitians tend to be focused on chronic disease prevention and management. So diabetes, cardiovascular disease, and older adults are not typically the clients that are seen by these dietitians, unfortunately. You can see we've got a similar process that we had for transitions about linking people to community services as a way to keeping them out of hospital and keeping them well nourished, things like meal programs, etc. I'm going to move on and show you some of the community-based treatments we know to be effective specifically to older adults, and then show you the basic care plan that can be implemented by a nurse practitioner or physician. So counseling, either by telephone or in person, by dietitian or nurse, actually can improve food intake in older adults' function and nutrition status. When using oral nutrition supplements in the community setting, it improves their weight, quality of life, and survival. Counseling with ONS together, we see decreased falls, quality of life and food intake, weight and function. Didactic education, where it's more of a group-based education, improves food intake, knowledge, and nutrition risk. Suggesting vitamin supplements can improve the serum levels of those nutrients. And then finally, meal programs can increase intake, decrease nutrition risk, and prevent ER and hospitalizations as well. Again, several references showing the benefits of treatment when people can get it. The key, again, is getting them into the treatment. So here's the basic nutrition care plan that we suggest. And so we think anybody could do this in terms of a primary care provider. It could be a physician or a nurse practitioner. And so basically the idea would be to educate the client on their nutrition risk and to document it, investigate those potential reasons for nutrition risk, promote an energy and nutrient-dense diet, so again, a food-first approach, and then follow up. And if you need to, institute oral nutrition supplements for these individuals. And so we have a 4-page fact sheet that's on our website for the Canadian Malnutrition Task Force that helps providers go through these steps and learn how to do it. So again, trying to basically get more of a multidisciplinary way of addressing malnutrition, because it is so prevalent in older adults. We don't have enough dietitians in the community setting to address it. So where can you find all these resources? They're on the CMTF website, which is the Canadian Malnutrition Task Force, which I'm part of. We've been the group that did that original study in hospital, the 1,000 patients in 18 hospitals, and we moved through to being more knowledge translation and developing best practices, as you can see from my talk today. I just wanted to highlight for you, this is the website here, but some of the key things we created this year. We have a Canadian Malnutrition Awareness Week every October, and we create infographics and videos to support awareness raising in the community around malnutrition. So we created nutrition screening, 2-page flyer for your nutrition screening for your child, meant for parents. Primary care providers are your older patients at nutrition risk. We created a 2-page fact sheet. And for long-term care, we created a fact sheet around enhancing or enriching food in long-term care. So CMTF started as just hospital malnutrition in 2010, and now 15 years later, we're doing every sector of care. We're doing research and we're doing knowledge translation activities to try to address this very prevalent issue of malnutrition. And here we have some other posters for hospital. We made some pamphlets to give to the patient when they come into hospital. I don't know if that happens in Taiwan or not. Tray liners, so when you freeze on a tray, you can actually see, get some information about how you might think about eating your meal and trying to prevent malnutrition. And similarly, when they leave hospital, some things that they can be doing to try to prevent malnutrition again. So again, the idea of self-management, giving some control back to the patient. So I'm going to wrap up with talking about lessons learned in implementing screening. So just back to the hospital sector, we had that study that showed gaps in nutrition care. We then created the integrated nutrition pathway for acute care that I showed you. And as I said, dietitians especially were saying to us, well, there's no way we can do this. You're going to find too many people to be at risk. There's no way we can assess them all and treat them all. And so we wanted to show them through a study that it was feasible and acceptable to do this and actually could change their practice and improve the outcomes of older adults. Before I show you that, I actually wanted to just show you this recent article by Dent last year, showed that this is a problem worldwide. The idea of getting screening into place and getting nutrition care happening for patients. And so they have a very nice review paper, and there's a figure in the middle of that review paper. It talks about older adult weight is not being done in primary care. So for those of you that work in primary care, is older adult weight being done? No? Yes? No? Hands up? It is? Good. Great. General practitioners do not consider malnutrition part of their scope of care. I'm seeing here in Taiwan, it's different. There is more of a multidisciplinary feel, but perhaps there are some physicians who don't see nutrition as part of their care process. Certainly in Canada, they don't. We're a fee-for-service group, and so when the physicians, and they don't get a fee for identifying nutrition risk or malnutrition. So it drives their practice, obviously. Healthcare professionals lack knowledge on nutrition risk screening. Would you say that is consistent with Taiwan and Hong Kong and other places? Is that true that people don't know how to do this? Yeah. Healthcare professionals have negative views on malnutrition and nutrition. So when we first started some of this work, some of the physicians say, well, of course they're malnourished, they're old. Well, no, that's not necessarily correct, right? Screening is not always completed properly. Validated tools are not always used, and we found that certainly in our study, and I'm sure in your own case you might find that too here in Taiwan. Those at risk by screening are not always followed up. So that's another big problem that happens worldwide, that we might screen and then nothing happens, which is not a good process. Those at risk by screening barriers to screening and follow-up are not being addressed, like time, knowledge of the people that are doing screening, training. Lack of individualization of care as well, especially in the community. Multidisciplinary team is not aware of the potential role in the malnutrition care, especially, again, in the community setting. And then finally, dietitian care often occurs too late. And so we saw this in our malnutrition study, that those patients who got to see a dietitian tend to be those that physicians or nurses thought should see a dietitian. They had diabetes. Well, if you come into hospital with diabetes and no other reason to see a dietitian, it's kind of a waste of a resource, right? But if you come in being malnourished, you should be seeing a dietitian. That was not happening. And the other, when we found people staying in a hospital longer than expected, that's when a dietitian came in, because they realized the person's not eating. They're not getting out of bed. Or maybe they need a dietitian referral. So it's coming way too late in the process. And in the community, I think that's the same case. Some geriatricians that are in Alberta do screening quite a bit, but they're geriatricians, which is a specialized service. And they say it's actually a little bit too late by the time they come to me to be doing screening. That should have been happening in primary care with the first provider. So back again to the integrated nutrition pathway care, just to show you this is what we tried to implement. And so, as I said, dietitians especially were very concerned about this. They thought there's no way we can do this. It's going to overload our system. So we did an implementation science project called More to Eat, and we had 2 phases. The first phase was 5 hospitals and 1 medical unit in each of those hospitals. And the intent was for them to implement over an 18-month period the integrated nutrition pathway for acute care. And they were given some money to support doing that. Phase 2 was 10 hospitals, 4 of the original ones plus 6 others, and 21 medical or surgical units, including some of the original units. And so you say, why do you have to do phase 2 after phase 1? Well, the complaint was that we gave them money to implement. And people said, well, in reality, you can't implement if people give them money. In our system, we're not going to have an injection of funds to do this implementation. So phase 2, we didn't give them money for implementation. We gave them only a little bit of money for data collection and showed that, yes, we can still implement when you have some key ingredients for implementation. So key to implementation was, or things we wanted them to implement, were screening for sure, medication pass of oral nutrition supplement to make sure that patients were receiving this. The nursing staff would portion out a high nutrient-dense, energy and a protein-dense oral nutrition supplement in 60 ml aliquots to give to the patient and make sure it was consumed. And SGA, subject global assessment, was key. So those are 3 key activities that everybody had to do. What I'm showing you here is the nutrition risk screening. So phase 1, we had, you can see the uptake of screening over the period of time of implementation, relatively low, to over 80% of all the patients in these 5 units over a period of 18 months. Phase 2, we had the original units, which is the square box on the line. We had phase 1, which were new units in this hospital that already did phase 1, which is the sort of starred box, triangle box. It's one in the middle anyway. And then phase 2 are totally new hospitals. And it's the starred one that's on the bottom line. And the key thing to see here is that there was a 2-year period in between phase 1 and phase 2. So hospitals in phase 1 were able to retain their practice in those units. So it was sustained. So whatever we did, it worked, so it stayed. And often implementation, it doesn't stay, right? That's the trick. Also, the phase 1 hospitals that had new units were much faster uptake because they had seen their colleagues in the other unit how to do it. And the processes, like putting the screening on the EMR, for example, had been thought through already in that hospital, so it was easier to provide uptake. And obviously the phase 2 hospitals had a very similar trajectory as phase 1, new to the process, but could do it. And this was a 12-month window versus phase 1. I'm going to show you some of the outcomes in just a moment, some of the slides for that, so I won't belabor that at this point in time. So how do we do this? So implementation is, we often talk about interventions getting put into place, but we don't talk about how that happens. It's often a black box. So implementation science is about how you actually get these things into place. And so these are a variety of techniques that we use. And I just got the notice about time, so I'm going to skip over this. But the key is that there is behavior change theory and frameworks that can be used to support implementing a new practice in hospital and community. And it's a key part of getting things like screening into place. So here we showed, this is in phase 1, mealtime barriers went from 2.5 on average to 1.8, so a significant change. Remember that standard care practice and the impact we talked about was a key issue, and one of the outcomes was decreasing food intake barriers to for people. Here is, again, phase 1, length of stay. In 4 of the 5 units, a significant drop in length of stay. And because it's 5 different provinces, it can't be something going on in the province, like change in fee structure or change in the population or something like that. 5 very different hospitals, all but 1 had a decrease in length of stay because of this process. And then here we can see in phase 2 that basically screening, once you got into place, it drove all the other care practices. So for example, medication change due to a GI condition, that was only happening about 30% of the people at the first audit, but by the end, it's happening at almost half. So improved practices across the board because we put screening into place. So I had the good fortune of having a doctoral student who was very interested in theory development, and she created this framework for us to think about how to spread and sustain some of these practices. Again, I'm running a little bit short on time, so I won't spend too much time on this. But the key is that you have to create a culture of change. People have to want to make this change happen. It's not going to happen otherwise. And so we had to create a culture around nutrition and being important in the hospital setting. We had to think about having success in the initial stages of screening, for example, getting that into place and people seeing the benefit. So for example, an anecdote from phase 1, we had physicians, we did some knowledge, attitude, practice questionnaires with physicians and nurses, and we had some physicians who were very negative towards this. It's not going to change anything. We're not going to see benefits to our patients by doing this. But at the end, they were champions because they saw the success of patients getting better food, quicker assessment, better interventions sooner, and the recovery of the patients happening much more readily. So some of the key lessons that we've learned. You have to have a champion to negotiate that change. And the key then for sustaining is to make sure the champions can transfer that role over, because we know that people transfer to different units and different hospitals or leave the profession. So you have to really be able to embed practices in a way that champions arise and stay and can be transferred over. Develop a positive organizational culture, as I said. Use behavior change techniques to make change happen. Build awareness of the importance of doing screening and nutrition care. You have to demonstrate the benefit and show that benefit to the staff who are doing this. So when nurses were doing screening, they realized they got to have their dietitians in sooner. That meant their patients were getting out of bed sooner, less likely to need nursing help to get to the washroom, benefited their care as well, right? They saw those benefits happening. You want to train, you want to automate the system if you can. So for screening, putting a screening tool into the EMR and an automatic referral process to the dietitian rather than having to make a referral through the phone or some other mechanism. Using tablets for self-administration by patients, for example. Make it into your policy. Plan your process and work through the process. Build relationships and do audit and feedback around the process. That's key. And so we found that you have to audit and feedback to get staff changing behavior and continue to keep that behavior in place. Yep. So just to let you know that where we've gone from there, we actually now have a malnutrition prevention, detection, and treatment standard from the Health Standard Organization of Canada. And it was developed because of this work to show that, yes, you could have a better practice, and this is what the better practice is, and it should be instituted in Canadian hospitals. And most recently this year, we actually have a campaign to work with try to influence the federal government around malnutrition care across all sectors of healthcare in Canada. And just to show you, when we did that study in 2010 looking at hospital care, screening was not happening at all in those 18 hospitals. Subjective assessment was not happening in those 18 hospitals. So in 2022, we decided to do a national survey, one survey per hospital, to find out what was happening, a decade basically after the initial study with no implementation on our part. What actually was happening? Now we were seeing screening was being taken up just because of the success of this work. We weren't implementing it. 36% had most patients being screened. 78% were now using Canadian Nutrition Screening Tool, again, before no one was using it. 76% were having a referral process to the dietitian, and 2/3 were using the subjective assessment. So we've changed practice in Canada because of this work. So where are we now? And I'm right out of time. We're doing something called Advancing Malnutrition Care because we recognize we need to spread this even further without any funding. So this is only through a postdoctoral fellow. We have developed a model where we have mentors who are in hospital who have done this, helping champions who are new to the process and helping them embed it in their hospitals. And we have almost 50 hospitals involved and 20 mentors helping these champions. And so we're studying that champion-mentor model. What makes that work? In summary, I hope you've gotten from this talk today that malnutrition and risk is very common in older adults, and it's an important healthcare problem. Treating malnutrition risk can support healthy aging. The issue is trying to identify these people so we can get them the treatment they need. We know treatments do work. And from the work from the More to Eat study and getting screening going, that will lead to a cascade of other interventions for individuals. Similarly, we expect that would happen in the community setting with the pathways we've created. We have good screening tools that are available and acceptable. You should look at where the sector of care is and choose the right tool. They're variable in terms of what they pick up and identify in terms of risks. And then finally, there's best practice pathways to support systematic care that now can lead us to a better care process. So with that, I'd like to thank you very much for your attention and can address some questions.
Thank you very much for an extraordinary speech. Very comprehensive and very informative. Hey, pretty girl, you run out of time. Do we still have time to 1 or 2 questions? Yes.
Probably 2 questions available.
Is there any question from the audience? Professor Arai.
Thank you, Heather, for your very excellent and comprehensive talk. So in my hospital, I always measure body weight in every visit. So in our electric chart, we have a tab, and when we click the tab, we can see the trajectory of the body weight. So it's easy to monitor the body weight. And also, I ask my patient about their appetite at every visit. Those 2 things are very important for our hospital. So it should be done in every hospital. But I don't think it's not the case.
Yeah.
My question is about lack of dietitian in the community. I think many countries we don't have enough dietitian in the community. So hospital is okay, but self-assessment or monitoring of nutrition intake is important, but it's difficult.
Right.
Self-assessment of physical activity or exercise is easy because we have a lot of tool. But personally, I don't know how much calorie or protein I'm taking every day.
Right.
So is there any way to self-monitor the nutrition intake in Canada?
So there's a variety of tools, right? So apps that people will use. Most older adults don't use those typically, though. So dietary intake is a bit different than nutrition risk, right? It's looking at that one component of a nutrition assessment. Certainly there are tools, and there's one app that's been created in Canada called Quinoa. And it measures, you take a photograph of your food, but then you also have to enter in what it is you're eating. And so this is the limitation, is that people writing that down can be a challenge because they may not get the portion size right, et cetera. So there's significant limitations, unfortunately, to diet assessment. I guess the trick is thinking about, so screen can actually be self-administered, which is a nice thing about it. And you can get people on the path to eating better without actually knowing exactly how much protein they're eating, right? And maybe that's what we need to be thinking about. So if they're not eating one serving a day of a meat or alternative, then they need more protein, right? And so educating them about how to eat more protein, get it into the diet, might be the step to go rather than trying to analyze in detail 63 grams of protein per day, right? So I think in the community we have to think pragmatically about what it is we're trying to do when assessing things, because it's really hard to assess diet, as you said. Yeah.
Basically, you focus on undernutrition in your talk, but how about overnutrition is a problem, especially after retirement. They have more time to eat, like snacks. So any strategy in Canada about countermeasure for overnutrition or in other people?
Okay, so again, screen actually measures weight gain. So that's the only tool I know of that's a nutrition risk screening tool that actually measures weight gain, not just weight loss. So that's one option. But when it comes to obesity management in primary care, I think for older adults, it's not where it should be. For example, I went to my doctor recently. I didn't even get weighed. They don't weigh people anymore. I don't know why that is. If it's post-COVID sort of event, you have to ask for these sort of preventative activities. So that's a significant issue. I know that there was a push towards putting waist circumference and body weight into primary care, but I don't believe that's being done. I haven't had that done for years and years. So it's unfortunate. Yeah.
Thank you.
And I don't know if it's the same here or not. Yeah.
Well, no more question. Because his eyes look at me. I have to close this session, and I know you will stay here for some moment. Your question just later on, okay? I have to close this session, and I want to express the gratitude to Dr. Heather Keller and all of you. Thank you.
Please. Thank you for the insightful presentation, and we would like to express our gratitude. Could we invite Vice President to represent NHRI to express our gratitude and for presenting the certificate and the gift?